So now we're going to talk about static low back pain, and then we talked more about that's where either you're doing repetitive postures for a long time, like you're doing the sitting and I'm doing the standing, right? I'm going to hurt more when I extend, or you're going to hurt more when we flex. You're going to blow out your discs, and I'm going to get facet syndrome. So again here, I put the wrong picture in there. That's the upper extremity. But the same thing happens in the lower extremity. It's like what I was saying, you have tight extensors, weak flexors, back hyperextends. It puts more pressure on the facet here. Okay. Over time, it can constress the tissues, ligaments become elongated, discs shrink, end up with the raisin disc syndrome. There's the right picture. So yeah, you have weak flexor muscles, rigid extensors, pelvic tilt, so you increase the sacral base angle. Now, with a situation like this, and you go and you have them do range of motion and movements, it's not necessarily going to produce the symptoms, because we're talking about something that happens over a short period of time. No, we're talking about something that occurs for a long period of time. So if you're going to do range of motion and flexion, you're not going to have them stay like this and say, okay, I'll come back in a half an hour. They're only going to have the problems if they're sitting for long periods of time. So typical range of motion evaluation is not really going to give you much information with this. But when they say, when I sit for, if I sit for 20 minutes at the computer, that's when my back starts to hurt. So it's more long-term types of things. Because what happens is as you get in a static position, you get things that happen with the ligaments, they can relax, you get things called a creep and things like that. So it doesn't really affect the nerves, and then you're not really going to have some special tests. It's not like the 20-minute lumbar flexion test, right? All right, now we're going to move into disc injuries. So I think mostly the way this will end up is that today obviously is pretty much just going to be mostly lecture stuff, and then next time we'll be able to just do pretty much mostly examination stuff. So whatever, if there's a little bit left on the conditions, we might go over that next time, but we'll be able to practice a lot of lumbar stuff. So tables out, and practice a lot of that. So disc injuries, they can be either acute or they can be chronic. So you're going to have repetitive lifting, you're going to have prolonged sitting. And then again, I think we mentioned this in the cervical spine, is that the candidate for a disc herniation is going to be someone that's of a younger age that still has a disc in there, the bulge. You still got to have the raisin in there. Once it turns to a grape, there's not much left to herniate. I mean, it turns into what they start out with the grape, they end up with the grape. So there's got to be some kind of a nucleus pulposus in there to be able to herniate. But so over time, discs chemically change and dry out. So when you're in that transition area where the disc is starting to degenerate, but there's still something in there to herniate, then you can have a disc herniation at that point. If it gets to the point where there's not much left, there's nothing really there to herniate. So again, you get those different forces that act on the disc, torsion, shearing, and things that are going to weaken those annular fibers, and then the nucleus is going to squeeze its way out. So they're going to have some type of activity that's going to require repetitive lifting, proper position, and then we talked about that lumbosacral rhythm, if they're doing more extension rather than doing the pelvic tilt. Okay, so they may or may not have a range of motion limitation. A lot of times if they do, what's going to aggravate their symptoms if they have a disc herniation? Flexion or extension? Flexion. So again, obviously we're looking for dermatome, myotome reflex changes. Right? So then special tests, again, this is like a nerve situation. What kinds of tests are you going to do to test the nerves? You're going to stretch it, you're going to narrow the opening, so you're going to do stuff like straight leg raise. Sometimes you will produce symptoms if you do some extension stuff, because that's going to narrow the IVM. So you have straight leg raise, well leg raise. So again, you can have degeneration that can occur with the disc that makes it more likely to undergo a herniation. So here you're having some degeneration. There you have the anterolisthesis. As the disc narrows, it's going to slip forward a little bit. All right, so first you have, now we're getting into the progressions or the different pathologies of what happens with the disc. So this is something you need to make sure you understand for testing inclusions and things like that. Different pathologies of the disc, right? First you have degeneration. Okay, so you're not having any tearing or anything with the fibers, it's just the disc is wearing out and it's starting to shrink, and there's chemical changes. So like I say, you start out with a grip, you end up with a razor. Now when you're talking about protrusion, you have a disc that's bulging. So the disc is starting to squeeze out of its confines, but you're not having any tearing of the annulus fibrosus. The disc is just starting to break down a little bit and starting to protrude. So that's what's happening here. It's starting to, the nucleus is starting to spread out a little bit, and the disc is starting to protrude. It's expanding out a little bit. All right. Now you're starting to get a little bit more disruption of the annulus fibrosus. Then you start to get into a prolapse disc, where some of the outer edge of the annulus fibrosus is starting to contain the nuclear material. So the nuclear material has moved all the way out to the edge of the annulus fibrosus. And so then that's a disc prolapse. So you can see here, this is the spinal cord here, this is an MRI. So you can see there, the spinal cord looks okay, boom. So the disc has progressed to the point where it's disrupting the spinal cord. So then now you have disc extrusion, so it's extruding out. Right? So now you have the nuclear material is out beyond the confines of the annulus fibrosus and it's going into the epidural space. So that's an extrusion. Right? And then now you have sequestered. And then that's where you have actually pieces that are out free floating, so they've separated themselves from the actual annulus fibrosus. The nucleus, and it's going beyond the annulus, and it's getting into the affecting the spinal cord. And then here's sequestration. So again, the symptoms of the disc. What's significant about somebody that has what kind of symptoms are you going to be looking for when it's going to indicate a disc herniation? Where's the pain going to be? Yeah. Sometimes what will happen is somebody will come in and they'll say, you know, my calf is just killing me. I can't sleep at night. Does your back hurt? Well, it used to before, but now my back doesn't really hurt so much. Now it's just this throbbing pain constant in my calf. So a lot of times the pain started out in the back, and then now it's just in the legs. So you can have pain, you can have numbness, tingling, altered sensation. So the pain actually a lot of times is going to be worse in the distal extremity. So then again, we talked about spondylosis before. What that is basically just degenerative process. It can either affect the disc, and it can also affect the vertebral bodies. And then, like I said before, it has the anterolisthesis. As the disc narrows because of the alignment of the joints and the facets, the vertebral slips forward.